Thank you very much for the invitation to come today to give my talk. So yes, I am Gary Collins. I am a professor of medical statistics at the University of Oxford. And I'm also director of the UK Equator Centre, which I'll talk about a little bit more later on, and also director of the Centre for Statistics and Medicine, both hosted in the University of Oxford. So today I'm going to talk about transparency and why we need it in research in a broad sense, but also in the context of prediction models and predictive AI and how reporting guidelines can help transparency. So let's go back to the beginning. Hopefully we're all doing research, or we will do research in the future to advance scientific knowledge, in the healthcare domain. We want to try and improve patient outcomes directly or indirectly, lead to improvements in disease, treatments, prevention of disease. And that's all predicated on having a good research question. The answers are really clinically important need. The study is well designed. We carry out that study really well. We analyze the data properly. Then importantly, we report the study transparently and completely. And how do we disseminate those findings? So we've done the research. The important thing is now we've got to disseminate why we did this research, how we did it, what we found, and the implications. And that's usually via a scientific manuscript that we submit to a journal. So that manuscript itself should contain all the information we need so that readers can judge whether that piece of research has any value. And we should try and avoid over-interpreting our study findings, spinning or hyping up the research findings. So that's the kind of why we do research and the publication. Long gone are the days where research publications in the clinical literature are just for other doctors. No, articles now have multiple readerships, so it's other healthcare professionals, trying to learn how to treat their patients better. It's other researchers, designing their own research. They're trying to plan a similar study, but in a different setting. We may want to include that research in a systematic review where we synthesize the available evidence. Patients and consumers are increasingly reading medical journal articles, and policymakers, regulators, purchasers of health interventions will also need to understand information in your research publication. So it has to be transparent, it has to be complete, and we have to understand the research you have just carried out. And it's often the only bit of evidence to say that the study was ever done. In 10 years' time, you've all moved on to the next position or the next job. That publication, that DOI, that journal article is the only evidence that you ever did that study. It's important that we get the reporting right. It's an essential part of doing good research. It's part of research integrity. Increasingly we have to follow open science principles and practices, reproducibility, etc. So that really crucial component of your research is that article. Back in early this year, the Declaration of Helsinki was updated. So these are ethical principles about doing research on humans. They also recognize the importance of doing research that has strong methods, that is protocol driven. So not just clinical trials, but research in general should be protocol driven. We should declare conflicts of interest, our funding, expertise. But importantly, they in the yellow on the right hand side, they say readers have a duty to make their research publicly available on human participants. They are accountable for the timeliness and completeness and accuracy of their reports. All parties should adhere to accepted guidelines for ethical reporting. And if you don't follow these principles, then the declaration says that article should not be accepted for publication. So in the recent update, they're stressing the importance of timely and complete and accurate published reports of scientific research. Hopefully some of you might have heard of this chap on the right-hand side, Professor Doug Altman. If you Google Scholar him, you'll see he has nearly 1 million citations with a ridiculously high H-index and has been highly influential in the last 50 years in the health space. So if you've heard that quote, we need less research, better research, and research done for the right reasons, This is the chap who had that quote, and Doug was my old boss and had many good quotes. Another one of his quotes was, readers should not have to infer what's probably done, they should be told explicitly. So your research article, when we're reading it as a reader not involved in the research, we shouldn't have to guess what you did. We should be told explicitly in the manuscript why you did this, how you did it, what you found, and implications. We shouldn't have to guess. You know, so why do we need complete and transparent reporting? Well, in addition to trying to improve future research and future health outcomes, we also want to try and reduce what's called research waste. And that's research that has limited or no value. And poor reporting or incomplete reporting is a contributor of what we call avoidable research waste. You've done the hard work, you've got the money to do the study, you've gone through ethics, you designed the study, you've carried it out, but you haven't told the reader all the information they need. That's avoidable research waste. So back in 2014, there was a series of 4 or 5 articles in The Lancet talking all about trying to reduce research waste and increase the value of research. So in this paper by Paul Glazier and colleagues, inadequate reporting occurs in all types of studies, including animal, preclinical, diagnostic, epi studies, clinical prediction model research, which we now collectively call predictive AI, and qualitative studies. So across kind of like the research landscape, there are large swathes of unusable research, which we class as research waste. So we need to try and fix that through better reporting. So we started something called the Equator Network. So this was started back in 2006 as an initiative to try and enhance the quality and transparency of health research. So this was started by the late Doug Altman and Iveta Samara, who led the early phases establishing the network as the international authority it is today. So we collect reporting guidelines. Reporting guidelines are kind of like a checklist of things you need to include in your study. So if you've ever done a clinical trial or a systematic review, you may have heard of the consort statement or the prisoner statement. You know, and there are lots of different study reporting guidelines for various study designs. And they are just prompts for authors, for your authors, for me as authors, as checklists and reminders of things we need to include in our manuscript. They're evidence-based, consensus-based, community-driven, so fellow peers, fellow researchers in the area, multidisciplinary, you know, the clinicians, researchers, journal editors, funders, patients come together to derive these sets of guidelines. They're often accompanied by what we call an E&E paper. This is an explanation and elaboration paper, which is generally a very long document, a resource document, explaining why we need certain bits of information in your manuscript. So it goes through each item in a checklist and says why we need this information and gives you examples of good reporting. So what are we looking for when we are trying to report the sample size? There'll be examples in these E&E documents to help you. So it's largely an educational or didactic document for you to look at when you're doing your study. Here or two, I'm not expecting you to read the text, but you know, on your left-hand side is the consort statements, and on your right-hand side is the prisoner statement. So if you look at the prisoner statement very briefly, there's something called search strategy item 7. On your right-hand side, there's a column saying location where this item is reported. So you write, yep, I report this on page 6 of my manuscript. And for each of the items in the checklist, you report where you reported this in the paper. You may go down to the line number or the paragraph number. Quite often, the page number will be sufficient. Journals are increasingly asking you to submit these checklists, these completed checklists, when you submit your article. So I'm a BM Stats editor. We generally won't send out your paper for peer review unless there is a completed checklist. So if you've done your trial, done your systematic review, and there's no Prisma checklist or no consort checklist, your paper will be bounced back to you to say complete the reporting guideline. So they're firmly embedded in the research ecosystem and embedded in the editorial systems across the healthcare landscape. You will go to pretty much any publisher or in the healthcare medical journal, in their instructions for authors, there will be a mention, usually of the Equator Network or specific reporting guidelines. So, for example, if you go to JAMA, go to their instructions for authors, it says follow the Equator reporting guidelines. When you click on that, it opens up a huge another page of the types of reporting guidelines JAMA expects you to follow when you are submitting your article. On the right of the side, another main clinical journals, BMJ. You click on their authors, instructions for authors, and again, you are prompted to follow certain reporting guidelines for your research study. They're so important, integral part of doing research. ICMJE. So if you've ever submitted an article, or if you will submit an article in the future, you're quite likely going to be requested to complete an ICMJE form of conflicts of interest. And in that guidance, the whole section around the importance and the obligation of transparently reporting your study and following reporting guidelines. And they're just a few examples. Reporting guidelines and Equator are embedded throughout the ecosystem. But what's in it for me? What is it beyond informing patient care? What is it beyond informing future research? What other incentives are there? Well, there's a nice little study done here by Van der Poel looking at the quality and completeness of reporting in high-impact radiology journals, and they looked at whether the more complete the reporting, were there more citations to those types of articles. And they observed an increase in citations to papers that were more completely and transparently reported. And that's great, because as a researcher, we want our research to be used. But it can only be used if we tell the reader all the information they need so they can use it. So that's kind of like the build-up to the prediction side. So let's move on to prediction, and predictive AI is a hot topic. So I've worked in this area now since around about 2006, when it was pretty much a handful of biostatisticians working in this area. Roll on to 2015, 2016, 17, boom. Machine learning has taken a foot, artificial intelligence has taken a foot, and we've seen a huge increase in the volume of published literature in the healthcare space applying machine learning or AI-based methods. I'm not going to define that because it's a little bit murky, but it could be logistic regression, it could be a deep learner, a random forest, whatever. But there's a whole exponential growth in volume in this area at the moment. And just to also amplify or to illustrate, I think we're in this era of model mania, which I've called model mania. Here's an example of a single data set. So this is the SEER data set. This is a US-based cancer registry covering roughly 48% of the US population. So it's one data set, it's a cancer registry, very large, very useful resource. There are over 2,000 papers indexed on PubMed that are using just this single data set to develop or validate a cancer prediction model. Last year alone, there were 521 papers published using that single data set. So these are just models for oncology. Just trying to illustrate, 10 papers per week were being published developing a model using that single data set. So you can extrapolate that to other data sets, to other clinical areas. Now we're seeing thousands and tens of thousands, probably a week, being published models, whether they're regression or something more advanced using AI machine learning. Before the interest in machine learning, how was the reporting of prediction models? This is my area of interest. Primarily was in regression. And we know, through numerous methods of research, systematic research literature, that prediction models using regression models were quite poorly done. They were poorly reported. If you're doing a logistic regression-based model, tell the authors that's the kind of model you'll fit. In this study by Vanessa Bellew in the BMJ, 12% of the papers included in this study, 228 articles, 12% of those did not say whether they fit a logistic regression model or a Cox model. This is basic stuff. Missing data. Now, we can't do research generally without missing data. Missing data is just omnipresent. Even with a well thought out mechanisms, even in trials, there's usually some missing data, so we can't avoid it. Yet in this study, 64% didn't describe how they handle missing data. The output of a prediction model study is the prediction model. That's the bottom line. What is the model? How can I use that model in a different data set? How can I test it in a different data set? As a clinician, how can I use that model in my patients? And quite often, and this is quite shockingly high, 70% of the studies didn't report the full equation. So they may have missed off the intercept. They may have missed off the baseline survival at a time point or two. And without that information, we can't calculate a prediction. How we assess model performance is typically through something called discrimination and calibration. They're both equally as important, but quite often calibration is not assessed. So this is in the pre-machine learning world era. Things aren't great, so they needed fixing, and there's lots and lots of literature to show that literature hasn't been very good for a long time. So there's no point us moaning about this all the time. Can we do something to try and fix this? Can we try and provide a solution for authors to try and improve the reporting of prediction models in the healthcare literature? So back in 2010, we started the Tripod initiative, and this was a reporting guideline primarily focused on regression, because at the time nobody was really fitting machine learning methods. There was the odd neural networks, the odd support vector machine, but generally they were outweighed by the number of regression models. But the principles apply regardless of the model, but the focus was on regression. So this is a set of guideline to help you report your prediction model study. It's widely used, we believe. It's highly cited. Over 9,000 times. But there are deficiencies for the AI communities. Things have changed. But do they need to be changed? Is the machine learning literature better reported than the biostatistical literature that have used regression-based models? So we carried out 2 parallel systematic reviews or meta-reviews, one based in my group in Oxford and another set of systematic reviews based in Utrecht by Carl Moons and his group. And we looked at whether looked at the reporting, the methodology, whether these studies were high risk of bias or not, and whether the study or the findings were overinterpreted. And these were 2 parallel reviews, one done in the field of oncology, one just looking at general medical journals. And unsurprisingly, we did observe quite a lot of problems, again, in the design, methods, and reporting and spin. So there is a problem also in the machine learning literature as well. We looked at the adherence to the original tripod. So this is the tripod that wasn't initially designed for machine learning, but what we're seeing is quite poor reporting. So all those horizontal bars should be at 100% if they are all reporting all the information we require. So on your y-axis are the items in the checklist, so eligibility criteria, predictors, sample size, missing data, etc., etc. So for both sets of reviews, the reporting was inadequate. What are the consequences of this in reality? Well, you might have seen this paper in the BMJ. So this was a living review looking at prediction models for COVID. And over a 15-month period, we found actually over 1,000 models, but we looked at 606 prognostic models to predict and future outcomes in patients. 29% were at low risk of bias, so there was no methodological concerns. Things were generally well reported, but 545 of those 606 models were rated at high risk of bias. So there were problems in the methodology. And there's a small handful that were unclear risk of bias, so there were concerns around the methodology, but also some concerns around reporting. So in a time where models could have had an influence, to divert patients into ICU or not, or help prognosticate, these models weren't great. Out of 606 models, only 29 could have even a modicum of recommendation to be used on patients. We did this other study looking at, it's going to lead on to why it's also important in terms of interpretation. We did this study led by Evangela Christodoulou and Ben Van Kalster, looking at whether machine learning methods were systematically better than more complex data-driven machine learning methods. So we did this study, and we highlighted problems with small sample size, the poor handle of missing data, hyperparameter tuning, lack of model validation, etc., and find similar things we'd found in the pre-machine in the literature, but then also in those subsequent reviews of the machine literature, we found the same kind of problems. What does that mean in reality? Well, let's look at, we did all these head-to-head comparisons. We found all these head-to-head comparisons of trees, random forests, pop vector machines, neural networks, and various other machine learning methods, and we compared them to logistic regression, or what the authors in these papers we'd surveyed found. So if we ignore study quality and take the studies at face value, assuming they're well done and well reported, anything on that right-hand side of that vertical grey line is saying the machine learning method is better than logistic regression. Apart from whether you're using a single decision tree. So if you use some random forest, pullback machine, neural network, and if you pull them together, that black box is suggesting that logistic regression performs significantly and systematically worse than machine learning methods. Well, that makes sense. Well, let's have a look at the quality of those studies. Let's do a risk of bias or quality assessment and pull out the high risk of bias studies. So these are studies that are methodologically flawed or suffer from the poor report. And let's just focus on the well-designed studies. And that's roughly half of all the studies we included in the study. So half were at low risk of bias and roughly half were high risk of bias. Let's focus on the low risk of bias studies, the studies we think have some value. What do the results say then? Well, then surprisingly, the findings say actually logistic regression is no better systematically than machine learning. That was only predicated, we can only get to that conclusion if we stayed here and we thought, oh yeah, that's great, no point doing logistic regression anymore, let's go and fit random forests. But actually, when you dive into the methodology, when you dive into the reporting, actually, you can only trust those ones at low risk of bias. There's no difference. I think that's what we'd expect intuitively. Why should there be in low dimensional settings, non-complex scenarios? Why should logistic regression perform systematically worse? It doesn't. And this is really important because we don't want to implement methods or say, let's go and use a particular method all the time if it's not good. It's not good for patients. Where also we're seeing problems with reporting and questionable research practices. Well, here's a study done by Nicole White and Edgin Barnett when we published in BMC Medicine a couple of years ago. And what we did is we extracted 300,000 AUC values from published abstracts on PubMed. And you've probably seen, or you are aware of p-hacking or p-harking, where you'll see p-values just below 0.05 or just below 0.01. What we're seeing here are spikes of AUC values just above 0.7, just above 0.8, just above 0.9. Now, when you're developing a model and your model gives you an AUC of 0.68, your clinical investigator, partner on the project, might say, oh, can we just get that up to 0.7? What can we do to get it above that threshold? These thresholds are artificial, but what we're seeing something not quite right here. That histogram should be smooth because we're looking at so many AUCs, 300,000. That curve should be smooth. We shouldn't be seeing those little spikes just above 0.7, 0.8, 0.9. So that suggests there's something going on here, some questionable research practice. Could we circumvent this? Well, if we had registration or protocols, we might be able to circumvent that. We don't know if authors are cherry picking their findings. If we had registration or protocols and transparent reporting, these kind of shapes or patterns might be less pronounced. Open science, I think we're all expected now to follow open science practices. So we did this study looking at open science practices in machine learning studies in the field of oncology. We just took 1 month of papers published in the field of oncology that used machine learning methods. There were just under 50, and we generally found that adherence to open science was very poor. Very few shared their data. There may be a statement in the paper saying the data is available on reasonable request. We know from other research that those types of statements are pretty meaningless because just nobody shares the data. You email the investigator saying, can you share your data because you said it's available, but actually it's rarely available. The code to either reproduce your study findings in that paper or the code to implement the model, again, is rarely made available. 1 study out of 46 had a protocol. 1 study out of 46 was registered. And if we're doing a clinical trial or we're doing a systematic review, there's an expectation that you have a protocol or you've registered your study somewhere. And I think we should have those kind of expectations in predictive AI as well, increasingly so. Journals increasingly asking you to share your code or share your data. The BMJ from 2024 have asked you now to share your code or make a statement about the availability of your code. And as I've already said, data sharing should go beyond saying your data is available on request. No, we have to face reality. Not everything can be shared for legal or proprietary or ethical reasons. That's fine, but then just tell the reader, we can't share our code because of X, Y, and Z. We can't share our data for ethical, legal, whatever reasons. It's just about transparency. And earlier on, I said we have to avoid overinterpretation or spin. So you don't have to be an expert, I don't think, in prediction models to understand these 2 curves. So this is what's called a calibration plot. It's a plot of your predicted risk on your x-axis, and your y-axis is the actual or the observed. And these are lowest smoothed versions of these. And that red line is a line of perfect fit. And what we want is that black line to be on that perfect fit line. As you can see, neither the black line on your left-hand side or right-hand side lies anywhere near that diagonal line. Yeah, the authors have said the calibration curves showed a good agreement between the predictive risk and the actual probability. This is just outright spin. I don't know if they even looked at the plots when they interpreted that finding. But this is the kind of thing we need to guard against. So again, let's not moan too much. Let's try and find a solution to this. What can we do to improve the reporting of predictive AI? So we knew the original tripod wasn't designed for predictive AI. It needed updating. So back last April, we published Tripod Plus AI to provide recommendations for prediction models regardless of the modeling method. So whether you've done something like a simple regression model or done something more complex with a super learner or whatever, these guidelines now have been updated to cover all scenarios. We had 200 participants involved in a consensus-based process. So we're covering 27 countries. We have an online consensus meeting with a subset of these as researchers, machine learners, computer scientists, radiologists, healthcare professionals, journal editors, funders, patients, etc., to derive and update the Tripod AI reporting guideline. Here's the guideline. I'm not going to go through it. If you go to the BMJ website, in supplementary material, there is a fillable checklist. So just to repeat, the guideline is harmonized recommendations. So the recommendations are agnostic to how you develop your model. And we try to harmonize the language and terminology because there has been a divergence or sometimes a conflict in terminology between the machine learning and the biostats field. So we try to harmonize that or at least bring some clarity to that. It's the new guideline. It now supersedes the old guideline. So you shouldn't be using the old guideline now. Just use the Tripod AI guideline. We're currently writing a longer explanatory paper, so to accompany the reporting guideline to provide much more didactic information of why we need certain items in the Tripod AI reporting guideline with examples of good reporting, etc. And that will hopefully be published later this year. In the absence of that, in the supplementary material on the BMJ website, you will find something called an explanation and elaboration light, where for each item in the checklist, we have bullet points under each item to give you additional guidance of the kind of things we expect authors to report when you're developing or evaluating your predictive AI tool. There's huge emphasis on fairness. So you might have come across algorithmic bias or fairness. So these are issues to think about, when you're developing your model. You don't want your model to unfairly have an impact on certain underrepresented groups. There's the treatment of these groups. So society shouldn't be worse than those groups. And that's embedded throughout the checklist. Having representative data, evaluating the performance in key subgroups by gender or sex or ethnicity. And that's embedded throughout the checklist. We've asked authors, and we didn't include it initially in the original tripod, surprisingly, but we want authors now to explicitly say what clinical decision is the model you just developed intended to support. That should be a pretty obvious thing to do when you're doing your study. Why, what part in the patient pathway and what decision is that model? Why is your model needed? We're asking now, because there's concerns around the provenance of certain data, people are increasingly fabricating their data. We're asking authors now to provide a bit more evidence around the provenance of the data they're using. Talk about the richness of that data set. Why is it useful for the research question you're interested in? Is it sufficiently representative of the target population in whom you're going to use the model? How are you handling missing data? What are the sample size considerations? We now have, at least in the regression world, we have sample size formally or software now to calculate your sample size, both for training your model, but also testing. So PM-val sample size and PM sample size to do this. There's less guidance for non-regression based methods, but the sample size for regression should be a conservative baseline for doing something more complex. We appreciate that not all prediction models can be made available freely. If you're working with a tech company, they don't want to share their model, that's fine. I don't like that. I'm a science follower. But at least in your paper, you should explain, well, we can't share our prediction model because of X, Y, and Z proprietary reasons. That's just about transparency. In the new checklist, we also have an item on public and patient involvement. So increasingly, at least in the UK and I think elsewhere as well, there's an expectation that you have PPI involvement in your study. That could be from the design, conduct, reporting, or dissemination of your study. Often it's a requirement for funding that you engage with PPI, and some journals like the BMJ, for example, explicitly ask you to say, how was PPI involved in your research? If you haven't used them, okay, that's fine. Just tell the readers you haven't used them. And here's an example from some colleagues in France. They were developing models for predicting kidney failure and death, and they showed you how they used PPI in their study when they were developing their model. So it can be done. We have a new open site section, so we're asking authors to declare their funding, conflicts of interest. They're asking them to register the study where possible on clinicaltrials.gov or some other registration platform. Have a protocol. It doesn't have to be published, but at least make it available on the Open Science Framework, data availability, and code availability. All of this should be declared. Again, acknowledging that not everything can be declared, but just saying it can't be declared, why not? So that's tripod, but there are lots of other reporting guidelines in the AI landscape. So, if you're doing something on large language models, so the tripod AI does not cover generative AI, but there's a separate guideline published in Nature Medicine earlier this year around how to report your research if you're using large language models. If you're doing some early phase or safety studies in the AI space, so you develop the tool and you want to see if it's safe or look at the human factors issues or the human in the loop, can they use these studies? Then there's an early phase reporting guideline called Decide AI, which provides reporting recommendations for those types of studies. Once you've gone past that stage, so you've developed your model, you've done lots of validation studies, and you think there's some merit in your model, then you can go forward into, say, like a randomized controlled trial and actually see, does it improve patient outcomes? Is it cost effective? Does it change decision making? I would do that in a randomized setting. And in the AI context is the SPIRIT guideline for guidance for reporting your study protocol for an RCT. And then there's the consort extension for how to report your AI intervention study. I won't go through this, but you'll find these have been published in BMJ, Nature Medicine, and Lancet Digital Health. But there are lots of reporting guidelines that are slowly, or actually not quite slowly, but rapidly becoming available across the AI pipeline. So whether you're from the development or validation phase, so tripod AI, if you're doing an imaging study, tripod AI doesn't focus on imaging AI. There's another reported guideline called CLAIM, which was updated last year to CLAIM 2024, to provide recommendations in that type of study. If you're then looking to use your model as a diagnostic test, STARD AI, currently under review, will hopefully be available later this year. I mentioned Decide AI and SPIRIT and Consort AI. And the other reported guidelines are around CHEERS. CHEERS is a study around health economics. Is the AI intervention cost effective? And there are lots of other reporting guidelines currently being developed around chatbots. There's a chart guideline, TREGIs around ethical use of generative AI, etc. And there'll be lots more coming out in this space. Close to finishing up. So we have Future AI, which was published 2 weeks ago. This is consensus guideline for trustworthy and deployable AI in healthcare. And that's all predicated on transparency. And so we have these 30 best practices which we defined around making the tool fair, universal, traceable, usable, robust, and explainable. That's all underpinned by having transparency. And that's across the AI life cycle. It's crucially important. So to summarize, AI is rapidly become such a huge driver of innovative technology in healthcare. Massive potential to improve patient outcomes, improve decision-making, workflow efficiency, but ... it has the potential to cause harm if used incorrectly. It has the potential to widen existing healthcare disparities or create new ones. We shouldn't be introducing tools that create or widen existing health disparities. We need it to be trustworthy. We want it to be high quality, robust methods, well designed, but importantly, it has to be completely and accurately reported. Yet we know there's lots of evidence to suggest that AI research is not well designed. It's often poorly conducted, and the reporting is suboptimal. So we have these tools like Tripod, like CLAIM, to hopefully improve the completeness of reporting across the research pipeline. And I'll stop there. Thank you very much for listening to my talk.